Okay, we've got a case sent in to evaluate site number 11. Looks like the patient is missing 11, 12, 13, maybe 14. I don't know exactly um, if they're missing a premolar on this side or not, but it looks like it's 11, 12, and 13. And then looks like we're planning on an implant on site number 7 and 8. So my first comment is when we try to put an implant on site 7 and 8, we've got to be really careful about being able to maintain the interdental papilla, have enough space between the implants. So let's take a look at number 11. And his question was, will I have to graft? And the answer is, in this particular case, yes. No question. There is significant resorption here. Um, there's the significant resorption here, and we'll definitely have to graft. In looking at this plan, I do like the implant size. I may consider going a hair longer, and the reason is what I would like to do maybe is look at the possibility of doing a placement and graft simultaneously. A lot of it will depend on the aesthetic needs of the patient. Um, in other words, I would extend my flap all the way to about right this point right here, and then drill my osteotomy, place the implant, decorticate the bone, add bone, place a membrane, and put everything back together again. Uh, there are some risks in this. It's not as predictable as we may like it to be. Certainly in the molar area, we have a lot of room for error, but here in the anterior region, it becomes a little bit of a question. So oftentimes, what many people like to do is flap, graft, pre-implant, let it heal, and then come back and place the implant. So we'll agree with that here. So while I'm here, I'm going to go ahead and take a look at these other implant placements. And um, I know we're fans of the Bicon implants, and certainly they work and they're nice and short. My concern with this implant right here is I think it's too wide for the site. Um, because of Bicon, the way the drill process is you're actually going to remove all of this bone to press fit the implant into place. And we're going to basically remove all of this lingual cortical plate. So if we were taking a closer look at this, what we would see is this is the bone right there. So if we drill all of this away, and for the Bicon system, you're going to be drilling everything you see here in magenta, and that'll be all of this right here will be drilled away, including all of this right here. So we might leave ourselves plenty of room on the buckle here, but we really are going to end up losing a lot of bone or potentially losing a lot of bone here on the palate. So I would maybe consider going to a thinner implant, moving the implant over to the buckle a little bit. Again, this will bring it outside the occlusal plane. So then maybe tilting it back in, maybe tilting it forward a little bit, and looking at something like that as my position. Again, I'm just not a big fan of these implants for this particular reason, especially in this site. I personally would look at maybe, a 4.5 by 8, 4.5 by 10 active implant, do a internal sinus lift. I think we can achieve that relatively predictably. So I would go for something like that because I can make a thinner osteotomy. I can preserve my buccal plate, the lingual plate, not because of the implant necessarily, but because of the drilling sequence necessitated by the implant choice earlier. So that's kind of what I would look at there. And the same thing here. I'd be very concerned about how thin we're going to leave this buccal plate area right here. So on something like this, I would probably, again, I personally would choose a different implant, but maybe something like this would work pretty nicely here on this particular implant. So hopefully that helps. Let's go ahead and take a look at tooth number 8. Um, ooh, I would have concerns on this one about the buckle plate or lack thereof. There seems to be a buckle plate there, not as clear as we'd like it to be. And the reason it's not as clear is the scatter from the post there. And see how the post looks to be going through the tooth there. That would lead me to believe that the buckle plate may not be there anymore. I would be a bit leery of this particular case, simply from that perspective. But let's just pretend the buckle plate is there. I think the position here is too close to right there. We're not getting a lot of stability. The tooth ends about right here. So we just have this area and bone. There looks to be like maybe a little bit of a defect right here. So personally, what I would look at doing here, going to a wider implant, placing this a bit more lingual, just like so. And now we're going to be engaging good bone. We have more space here. We can graft this area and the gap in this area and maintain some of that plate. But there's a good chance when we extract this tooth there's going to be no plate right there and maybe a site where we have to preserve and come back in. If we take a look at your plan here on number 7, again, I'm not comfortable with how close we are to the buccal plate right here. My suggestion would be, in looking at this, we're coming out the buccal of the incisal edge. So I would first move this back, and then I would try to get some engagement here. And I would probably be placing that implant more like so. That way I'm getting fresh engagement bone and somewhere along this line, so I have a little more space here to preserve. We have to expect to have some bone loss here from the loss of the tooth. So by having it too close to the buccal plate, we bring in issues. The next thing on this particular one is we're definitely pointed here to the distal. So I would come in and just move it like so to the mesial. The bigger issue in this particular case is going to be the ability to maintain the bone in between the implants to maintain the papilla. So it is somewhat difficult in these cases. And then the other thing to look at here is the incisive papilla or incisive canal is right here. So we have to take a look at how the implant, or it looks to be right there, how the implant is affecting that. Actually, the incisive canal is right there. So we're okay in terms of the incisive canal. But we have to make sure we have enough space. Right here we want a good 3 millimeters of space there to be able to maintain that interproximal bone. If anything, I tried to shoot this over just a hair there. So hopefully this is helpful and gives you an idea.